I'd just like to say what a terrific meeting this is. I'm just inspired by all the talks we heard this morning. I think they're all fantastic, and I'm all excited about the possibilities for ocular oncology and ocular melanoma collaboration in Australia. It's really fantastic to see what's happening. So my original talk on the program was a surgeon's perspective, but when I saw Bertel, one of the godfathers of ocular surgery, who pioneered many of the surgical techniques that we routinely use, was speaking, I thought I'd change the title, and I called it a multidisciplinary perspective, which actually turns out very similar to the talk title that Bertel had. However, but you know, here we just see such a diverse meeting and so interesting, and I really congratulate Anthony and the organisers on this initiative, and I hope we have more in the future on a regular basis and develop this idea. So I'm going to confine my talk to multidisciplinary approach to patient care. Just mention in passing that this concept here of AOMA, of networking and a multidisciplinary approach could be a good platform for closer collaboration that we were talking about earlier in Australia for pushing forward in this area. So multidisciplinary patient care, of course, is epitomised by the multidisciplinary team meeting. I'm going to talk mostly about this. We've had an MDT meeting here in Sydney since 2015. It's quite a unique meeting in that it's multi-institutional. It happens next door at the Kinghorn Cancer Centre. It's sponsored by the Save Sight Institute of Sydney University, and it's regularly attended by members of Sydney Eye Hospital up the road and also Prince of Wales Hospital. So why the MDT approach to patient care? Well, first of all, the fairly obvious statement, as you're seeing in this conference, that cancer care is becoming increasingly complicated. There are a large number of healthcare professionals involved right from the very start in diagnosis through treatment and including ongoing care and surveillance. And there's, fortunately, an increased variety of treatments available. And here we see the current list and increasing of the treatments available for ocular melanoma. Of course, the traditional treatment was enucleation, which we're doing less and less, or even exenteration, where the entire orbital contents are removed with very advanced disease. And then there's the various forms of radiotherapy. Plaque radiotherapy, we'll hear more from Claire, no doubt, is still the mainstay of treatment. Stereotactic radiotherapy has been refined greatly in the last decade or two, and we're certainly using that more often. Proton beam therapy also very effective and available in many places. Local resection, we had a wonderful talk this morning from Bertel. He showed you some of the various techniques of local resection, which are still very relevant for selected patients. And then we have the various forms of laser treatment, the transpapillary thermotherapy, photodynamic therapy, and very interestingly, a new laser technique, nanoparticle therapy. And I'm very much looking forward to Jodie Rich's talk tomorrow, who's a very knowledgeable person and also has had this treatment and is going to provide us with his insights. And then, of course, to remember that when we're talking about ocular melanoma, we're not only talking about uveal melanoma, as was discussed, we're also talking about conjunctival and eyelid melanoma. And we're currently using topical chemotherapies for these. And then there's the systemic targeted and immune therapies. And as we all know, there's nothing available in that space yet for uveal melanoma. But the skin systemic treatments, even now, have application to certain patients with ocular melanoma. So just to touch on that for a second, and to remember that uveal melanoma, as we know, has a very different profile of mutational drivers, but mucosal melanoma, such as conjunctival, is quite similar to cutaneous melanoma, with quite a high rate of BRAF mutation and some of the other driver mutations that are found in skin melanoma. So I just thought I'd share this patient with you, really just to illustrate the increasing complexity of the ocular oncology patient, and also to show you some of the uses of systemic treatment currently. This was a patient I was involved in the care of who had a locally advanced conjunctival melanoma. So he'd had previous resections of the melanoma elsewhere and he got a recurrence and he presented with this mass which is invading the anterior orbit and the eyelid, and his surgeon had recommended exenteration. He was a young guy, he was very active, he played a lot of sport, and he was very resistant to this idea, and he was seeing many people for second opinions. And I suggested that he get a targeted mutation testing, and he was found to have a V600E BRAF mutation. Fortunately for him, because that is a druggable mutation with the new targeted therapy. So here we have a man who has locally advanced disease, no known metastatic disease, in collaboration with the Kinghorn and our friends at the MIA Centre. He was commenced on dual targeted therapy in January 2016. You can see here by April 2016 he has complete clinical remission. And I saw him only a few weeks ago, and you can see he still has 675 vision, he has a healthy looking eye, no evidence of recurrence of his disease. So he has been cycled through different targeted treatments due to some side effects, but he's still going strongly. Now, who knows what the future holds here? It's sort of the vanguard of the treatment for these sort of patients, but it's certainly been a very good response for him so far. But really, I put this up just to show you how the complexity has increased for our ocular melanoma patients. Maybe 5-10 years ago, he would have had his exenteration, maybe seen once or twice a year by somebody, and that would be it. Now he sees me every 3 to 6 months to check the eye. He sees his local oncologist every few months, and then he has regular screening studies, PET scans, CT scans, whatever. When he comes to Sydney, he lives quite away from Sydney. So the MDT approach here, the multidisciplinary framework, allows all these specialists managing patients such as this to work together to develop a coherent patient care plan. So the MDT is a very convenient tool to improve communication, decision making and coordination necessary for this type of care, which is increasing. This improves patient understanding and satisfaction. That's just my personal impression, anecdotal. I will be very interested to hear what Bertel has to say of the factors tomorrow that are associated with patient satisfaction, good patient outcomes, but I feel that certainly introducing patients to a multidisciplinary approach to their management is probably one of them. So this is just another perspective, a paper recently in the European Journal of Cancer from the European point of view. It was a group that was set up by the European Commission, and they put together a multidisciplinary policy statement really on MDT care. And the first interesting point they made is that there's a paradigm shift for management of cancer from a disease focus towards a patient-centred approach. And we're now increasingly paying attention to the psychological aspects, the quality of life, patients' rights, empowerment and survivorship and not before time. And the multidisciplinary tool emerges as a practical necessity for optimal coordination among health professionals and clear communication with patients. So what are we trying to achieve here in practice just locally in Sydney and New South Wales? We're trying to encourage all ophthalmologists who treat ocular melanoma, and especially general ophthalmologists who treat ocular melanoma, and there still are quite a few who are treating conjunctival melanoma and eyelid melanoma, etc., to engage in an early team management model to support people, clinicians, surgeons managing these conditions. So what this means is trying to encourage our colleagues to utilise the resources of the multidisciplinary framework at an early stage, rather than leaving it till a later stage to help plan and share in the management of their ocular melanoma patients. This is in contrast to the traditional way these patients have been managed, where usually a multidisciplinary approach has been minimal, or at best late stage multidisciplinary input when there were problems or disease had become advanced or recurrences, etc. And many studies now showing that patients do better on a number of parameters with this approach. So we're transitioning to an early multidisciplinary team management framework. How do we run our MDTs here? So with patient consent, we welcome referrals from any treating doctor, usually ophthalmologists, but sometimes oncologists, orbital surgeons, and others. We also welcome pathology referrals for pathology reviews. So we will actually do just pathology reviews. If there's a pathologist who has, in the community, who has an eye case, they're welcome to refer the case to us for a pathology review. This is because many general pathologists lack eye pathology exposure, and they're very welcoming of this sort of support resource. Now, we meet actually only every 6 weeks, and we recognise that this is not often enough. However, we have to do our best with the circumstances that we have, and everywhere is different. You know, the UK is going to be different to Australia. We've got a vast country, small population, rare disease, a limited member pool for our MDT, and our members come from all over Sydney, and they come pro bono after hours. So you have to achieve what you can achieve. So we meet every 6 weeks, but we get around this a little bit by having virtual meetings of a quorum of core members, more often on a clinical needs basis, and we're also looking at launching telemedicine to our MDT meetings later this year. And that's our coordinator and the contact details if anybody would like to contact us. So we all know this, but just to run through, you need a core of professionals to run an eye MDT. You need an ophthalmic oncology surgeon specialist. There's 2 and now 3 in New South Wales, and I welcome Leanne Lim, who's just returned from doing her fellowship with the Shields, and she'll be joining Michael and I, and Adrian as well. We have 4, actually, ocular oncologists here in Sydney now. We have medical oncologists with an interest, radiation oncologists with an interest, radiologists and pathologists. As Bertel pointed out in his talk, it's absolutely critical to have a manager, a full-time professional coordinator manager to run these things. And so that's our quorum, our core members, and then we have often a social worker who attends. But of course, not to forget that part of the MDT, an element of the MDT, is always the primary care physician, community carers, and of course the patient and the family, not least of which. These are important stakeholders who, if not physically present, always need to be considered within the multidisciplinary framework. So just specifically on that point of the involvement of the patient, patients are always implicit members of a multidisciplinary team approach to their management. Some bodies, such as Cancer Australia, have actually advocated that patients explicitly participate as members of a multidisciplinary team. I've not experienced that set up personally. But whatever the format is of the MDT, it's critical that patients are kept informed of what's happening in terms of collaboration and communication between MDT members. They need to be supported to have as much input as they wish into their treatment planning. If treatments are recommended, they need to be fully informed of pros and cons in an understandable form. That's sometimes a problem that we talk in jargon. And preferably in a written form so that they can take away and discuss it with their family and so forth. Supportive care is a critical element which we're getting better at. I think that's something we tended to neglect a little bit in years gone by, but supportive care is integral, and also showing patients how to access those support services if they need it. Patients with cancer feel that their care is therefore coordinated, holistic and not fragmented. Planning a patient's care plan, even if formal MDT referral is not possible or not involved, multidisciplinary approach planning is still very helpful. And this may simply involve informal multidisciplinary review by referral to colleagues, and I often do this as well. And there's often a lot of anxiety when you first see a patient and their family about urgency to do something, or they need the thing cut out tomorrow or next Monday or something like that. But I tell patients that a little extra time spent planning the patient's treatment course using a multidisciplinary model is time well spent, because accurate staging, complete treatment of the primary tumour at the first treatment episode with individualised follow-up is critical in the success of their treatment in optimising their management and the outcome. This gives them the best possible chance. And a number of studies actually have pointed to the poor outcomes of ocular melanoma, especially conjunctival and eyelid, when treatments are not well planned. And there's a number of papers that allude to that. So advantages, there's a number of published papers talking about the advantages to patients, shorter time frames from diagnosis to treatment, revision of diagnoses, more accurate diagnoses, psychological support, increased access to information, increased access to clinical trials, improved satisfaction, improved survival in some cancers. There's some studies showing improved survival in breast cancer with an MD approach. Also advantages for the health professional, agreed treatment plans, streamlined treatment pathways, coordination, educational and research opportunities, data collection, improved mental well-being of health professionals. But of course, as with everything, there are challenges and dilemmas. This is not the traditional way that ophthalmologists have worked, but that's simply a matter of educating our colleagues. You could argue it may be excessive for some good prognosis tumours at an early stage, requires some infrastructure and administrative facilities, which some centres may not have. And of course, there are logistical issues of a small pool of specialists available to participate in these meetings. Also, as I've mentioned, the MDT may not meet as often as needed, but there are ways around that with technological advances. One other thing to consider is there's a need to have well-defined lines of responsibility so that actionable recommendations from the MDT are followed through, preferably by a nominated specialist. So if the MDT makes a recommendation, we always try to link it to a particular person. You know, we recommend a PET scan or something to be performed by Dr. X, so that there's some responsibility in terms of carrying out the recommendations of the meeting. So I think I might leave it there, and I'd like to thank particularly Tessa, who's our coordinator, Svetlana, who puts an incredible amount of effort into setting up the MDT pro bono, a lot of after-hours work. All our MDT members, some of them travel right from up the northern beaches of Sydney after hours to come and participate, and of course the patients. Thank you.
One question, but you want to just speak loudly?
Thank you very much for that great talk. One thing I found very useful is to have a very detailed protocol, how to cope with specimens, what every member of the team should do, who's who in radiotherapy and oncology, and how to contact them, all these kinds of things. And in Liverpool, I had it all on a Word document, which kept going out of date very quickly.
Yeah.
And then subsequently, I created a website which could be updated very easily, and it was always up to date, and people didn't have to look for a paper document. They could just go online and see that.
Yes, I think that's a good comment, Bertel. We might even pinch some of your ideas there.
And the second thing is that I've always focused on the patient, the patient.
Mm-hmm.
And I've ignored the person behind me in the corner. And relatively recently, I've realized how important it is to pay attention also to the spouse or the person accompanying the patient,
the person
who's actually looking after the patient.
That's right.
And improving their well-being.
That's right. And the second pair of ears and the brain's trust sometimes. And yeah, it's very important to include all these stakeholders.